I hold pharmacology part 4 basic sciences. Sometimes they will ask you the questions with respect to the bias block. See, bias block is very important for procedures below the elbow or the leg below the knee, and the procedure should be completed within 40 to 60 minutes. The local anesthetic solution is then injected slowly into the cannula. Anesthesia will occur within 3 to 4 minutes. And a very important point, the surgery, the pressure in the tourniquet must be maintained at least 50 millimeters of mercury above the patient's systolic BP. The drug of choice is prelocaine. Bupivacaine should never be employed. See, it will be like this. If we are performing a procedure in the distal arm, so now the BP cuff is placed at this point and the pressure is raised more than 50 millimeters of mercury. Here, distal vein cannulation done. In that case, the intravenous regional anesthesia is performed, and the maximum dose of lignocaine is with adrenaline, which is 7 mg per kg. Without adrenaline is 5 mg per kg. For intravenous regional anesthesia is 4 mg per kg. And if they're asking about lumbar puncture, skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, dura mater, and arachnoid mater. Spinal anesthesia, injection in subarachnoid space, which is between the pia and arachnoid, and spinal cord inside the lower part of L3 vertebra in children and adults, and inside the level of L1 vertebra. Right. So sometimes they will ask you the questions about antacids. So antacids predominantly we want you to remember aluminum hydroxide, magnesium hydroxide as mnemonic. MD causing diarrhea, aluminum causes constipation. Aluminum slow acting, magnesium fast acting. Simethicone, which is a counter repellent. Megaldehyde composition of both magnesium and aluminum. Antacids are weak bases, right? And there is one thing called a milk alkali syndrome, which is hypercalcemia, renal insufficiency, and metabolic alkalosis. So alkalosis, hypercalcemia, and renal insufficiency occurs. But what are all the side effects of antacids? CO2 release, which will be causing distension and perforation. In hyperphosphatemia, magnesium is used. Side effect, it may cause osteomalacia. So my favorite question always antithyroid medications, which is we are going to discuss about each and every drugs. Thyroid peroxidase inhibitor, carbimazole, methimazole, propylthiouracil. These thyroid peroxidase inhibitors are high protein mild, safe in pregnancy. It requires multiple dosing, and it will also inhibit the peripheral conversion of T4 to T3. Propylthiouracil is hepatotoxic. It is safe in first trimester. Uses hyperthyroidism, thyrotoxicosis, Graves' disease, and thyroid storm, which is called as Bailey symptom complex. 5' dehydrogenase, type 1 and type 2. Liver and skeletal muscles. Type 1 is present, type 2 is present in RBC. This 5' dehydrogenase inhibition by propylthiouracil and propranolol. Carbimazole side effect, agranulocytosis, maculopapular rash. Carbimazole, if in pregnancy given, it will cause aplasia cutis, which is manifested as loss of epidermis and skin. Agranulocytosis, patient presents with sore throat. certain drugs that will inhibit the secretion these are thyroid constipating agents. They decreases the vascularity. They are useful in thyroid storm. Side effect iodism. Iodides are faster acting. How does iodism manifest? Angioedema, swelling of lips, flares, rashes, and lacrimation and salivation. So just look at this diagram. Initially, sodium at its input pump, iodine enters into thyroid follicles by oxidation, thyroid peroxidase enzyme, organification, and thereby it will form monoiodo and iodotyrosine. And from there, T3 and T4, it is stored and then released. From there, T3, T4 is secreted from thyroid follicle cells. Peripherally, the T4 is converted to T3. We know that T4 and T3. T3 is the active form. So, carbimazole, methimazole, and propyltyrosine, thyroid peroxidase inhibitor. Sodium at its import pump, thiocyanates and perchlorates will be there. And this thiocyanates, perchlorates, these are also produced by cigarette smoking, sodium nitropuracil, and cabbage. Peripheral conversion also inhibited by propranolol, propyltyrosine, amiodarone. Thyroid hormone secretion inhibited by sodium iodide, potassium iodide, and lithium. They will ask you about anti-diabetic medications, and they may ask you about insulin. So first point is rapidly acting is lag. Just Lispro, Aspantulocin. Short acting regular insulin which contains crystalline zinc. Intermediate acting neutral protamine hagedon sulfate. Longer acting ultra-lenti, Glorgin and Detima. Longest is Degludec. Just remember each and every point. Regular insulin can be given IV. It is available in crystalline polymer. So if it is given in subcutaneous form, it takes half an hour to reach. Because it is available in a polymeric form, it has to convert it to a monomeric form. 1 point. And this insulin Degludec is the longest acting insulin. Unlike insulin Glorgin, because Glorgin should not be mixed because the pH is at 4. And Degludec can be mixed with other insulins also, right? The addition of zinc makes it longer acting. So in this there will be crystalline zinc. In this that will be zinc. Further addition is present. All the insulin preparations are supplied at neutral pH 7.2 to 7.4 except Glorgin. Glorgin is supplied at pH 4. So therefore the Glorgin cannot be mixed with any insulin, whereas we can mix the Degludec insulin, right? We must discuss about anti-hyperglycemic agents. Just remember this table. It is a very important question if they ask you about anti-hyperglycemic agents. Oral preparation, parenteral preparation. Parenteral preparation, we all know about insulin. We just know about the types of insulin. GLP analogs like exenatine, liraglutide. Amylin analogs like pramlintide. Liraglutide is responsible to treat obesity. So, obesity with diabetes mellitus, the best drug of choice, liraglutide. Pramlintide to treat both type 1 and type 2 DM. This is amylin analogs. Oral drugs. which will release the insulin. That means they will inhibit the ATP sensitive potassium channels. Sulfonylureas are safe in kidney failure. First generation sulfonylureas are chlorpropamine and tolbutamine. Second generation glipizide, glyclazide, glibenclamide. Meglitinates, rapaglinine, naticlinates also releases insulin. What are all the other mechanisms? Biguanides, thiazolidinediones, alpha glucosidase inhibitor, D2 agonist, TPP4 and SGLUT2 inhibitor. Biguanides, example metformin. Pioglitazone and rosiglitazone belongs to thiazolidinediones. Acarbose and meglitol belongs to alpha glucosidase inhibitor. Bromocriptine a D2 agonist. DPP4 inhibitor, sitagliptin, vildagliptin, saxagliptin, allogliptins. SGLUT2 inhibitor, dapagliflozin, canagliflozin. Just remember this point. This chlorpropamine and talbutamide sulfonylureas, they have side effects. They will cause obstructive cholestatic jaundice, severe hypoglycemia, disulfiram-like reactions. Metformin, remember this mnemonic most. Metformin is useful in obese patients, sulfonylurea is useful in thin patients. Metformin is very important because this metformin sensitizes the insulin receptors, so it will help to overcome insulin resistance in obese patients. That's why metformin is useful in obese patients. Metformin, it will reduce macrovascular events in type 2 DM. The important side effect of metformin is lactic acidosis, megaloblastic anemia, B12 deficiency happens. Glimepiride will cause ischemic preconditioning, which means it will promote MI. Pioglitazone, bladder cancer side effect. Rosiglitazone will increases the levels of LDA and it will increases myocardial infarction. Alpha glucosidase inhibitors. This drug acarbose and meglitol, they will prevent the breakdown of the glucose, thereby causing flatulence. DPP4 inhibitor causing hepatitis. The safest drug in kidney failure is lenagliptins. SGLUT2 inhibitor, which will promote the glucose excretion in urine, thereby increases UTI. It will increase the risk of bladder cancer. Sometimes they will ask you about radioactive iodine. Iodine 131, which emits both beta and gamma rays. Iodine 123, which emits only gamma rays. Iodine 125 emits only gamma rays. So iodine 123 half-life 13 hours, 131 8 days. Iodine 125 half-life 60 days. So they will ask you about management of thyroid storm. Thyroid storm will cause a Bailey symptom complex: perspiration, tachycardia, restlessness, tremors, decreased sleep, increased bowel movements. Management: A, B, C, D. Just remember this mnemonic: hypanoic acid, beta blocker, CCB and diuretics. Other drugs: sodium nitroprusside and rapid cooling with cooling blankets. Hypanoic acid is an iodine containing agent. Propranolol inhibits peripheral conversion. Calcium channel blocker and diltiazem, which external cooling also, and corticosteroids, which is an anti-inflammatory reaction, and diuretics. I separately uploaded Wolff-Chaikoff effect and in a separate video in my channel. They will sometimes ask you about beta blockers. Just remember this mnemonic: ANS, atenolol, nadolol, and sotalol. These drugs predominantly they will be useful in thyroid storm, hypertension, inhibits peripheral conversion, and even pheochromocytomas. Contraindication: asthma, AV block, congestive heart failure, diabetic. Beta blocker will mask the symptoms of warning signs of hypoglycemia, so not used in diabetic mellitus patients. Third generation beta blockers, they have additional alpha blocking property. What are they? Labetalol, corbitalol, medroxylol, bucindolol. Release of nitric oxide by nebivolol. Potassium channel opener tilsolol, and calcium channel blocker corbitalol, beventolol, betoxolol. Beta 2 agonist celiprolol, cortiolol, bopindolol. Beta blockers also useful in beta 1 blockade, hypertension, angina, MI, CHF. Beta 2 blockade, pheochromocytoma, hyperthyroidism, tremors, and performance anxiety. They will sometimes ask you about opioids. I just want you to remember opioids. If you know the mechanism of action, it will help you. Mu, kappa, and delta. Mu. So it is sacrum. It is the mnemonic: sedation, analgesia, constipation, respiratory depression, euphoria, and meiosis, and truncal rigidity. If it is kappa in action, dysphoria, constipation, analgesia, CAD. Delta in action, spinal analgesia, modulation of hormone and neurotransmitter release. Opiates are generally contraindicated in biliary colic, head injury. Side effect: fentanyl causes post-op muscular rigidity. Opiates are generally contraindicated in infectious diarrhea and in patients with respiratory failure. If it is given, it will cause acidosis and CO2 retention. We know a very important drug, morphine, which is useful in MI as well as in acute pulmonary edema. And morphine is contraindicated in biliary colic patients. Codeine, dextromethorphan, these are effective cough suppressants. Loperamide and diphenoxylate for treatment of non-infective diarrhea, as it is contraindicated in the infective diarrhea. Pethidine to reduce the shivering after anesthesia. Action on alpha-2 receptors. And it is also, opiates are contraindicated in injury because of CO2 retention, as it will be causing respiratory depression. Just understand this classification of opiates. Naturally, opium alkaloids are morphine, codeine, and the congener of codeine is codeine. It will cause constipation. 3 C's you must remember with respect to codeine: constipation, cough suppression, and constriction of pupil causing meiosis. Semi-synthetic opiates are diacetyl morphine, heroin, and codeine. Synthetic opioids: pethidine, fentanyl, methadone, tramadol, and dextropropoxifen. Fentanyl is a transdermal patch. Pethidine, it will prevent post-op shivering. Pethidine is a very important drug because it will be metabolized by monoamine oxygenase type A and demethylase enzyme. By this enzyme, it will be converted to pethidinic acid. By this enzyme, it will be converted to norpethidine. Norpethidine will tend to cause seizures. So, in patients with renal failure, it will cause seizures. it is precipitated. Pethidine is the drug of choice, safest in MA and biliary colic patients. Fentanyl side effect post-op muscle rigidity. Fentanyl uses pre-anesthetic medication, decreases anxiety and epidural analgesia. Ramifentanil, the most potent drug. The drugs that will inhibit the cell wall synthesis, they will sometimes ask you about antibiotics, cephalosporins. I just want you to remember some basic key points. Beta-lactam inhibit the cross-linking. Vancomycin inhibits chain elongation. Phosphomycin, enol pyrophosphate transferase. Cycloserine inhibits alanine ligase enzyme. Bezitracin inhibits bactrophenol. So, the mechanism of action, a very important table. Firmly bind to bacterial cell wall, which is vancomycin, transglycosylase, chain elongation. Bezitracin, dephosphorylation of bactrophenol, beta-lactam, transpeptidase, and phosphomycin, enol pyruvate transferase. Cycloserine, which is alanine racemase and alanine ligase. And this is my favorite question, which is buy at 30 and sell at 50, which is a classification of antibiotics. 30 is ribosome. The drugs acts aminoglycoside and tetracyclines. 50 is ribosome cell. Streptogramin, erythromycin, lincosamide, linezolid. Aminoglycosides. So just look at this. 50 is ribosome, 30 is ribosome. The site of action and how does it act? See, first initially chloramphenicol acts at 50S ribosome. It will prevent the conversion from P to A site. Whereas translocation from A to P site is inhibited by macrolide, lincosamide and streptogramins. Aminoglycosides, they act at three important levels: initiation, misreading of mRNA, polysome formation. So freezing of initiation interfere with polysome formation, misreading of mRNA. Tetracycline acts at 30S ribosome. They inhibit tRNA attachment to the A site, which is amino acid site. Chloramphenicol 50S ribosome. They inhibit peptidyl transferase enzyme. They inhibit the transfer of peptide chain from P to A site. Macrolide, lincosamide, streptogramins, 50S ribosomes. They inhibit the translocation of peptide chain from A to P site. Linezolid, 23S fraction of 50S ribosome. They inhibits initiation. There are certain drugs called acid-resistant penicillins called vodka, which is penicillin V, oxacillin, dicloxacillin, cloxacillin, amoxicillin. Aminopenicillins are ampicillin, amoxicillin. Carboxypenicillins are carbonicillin, ticarcillin. Iridopenicillins are mesloxilin, acloxacillin and piperacillin. So as we previously discussed, penicillinase resistant penicillins are condoms, cloxacillin, oxacillin, nafcillin, dicloxacillin and methicillin. Anti-pseudomonal penicillins, carbonicillin, ticarcillin, mesloxilin, acloxacillin, piperacillin. Anti-pseudomonal cephalosporins are ceftazidime and cefaperazone. Treatment: meningococcal meningitis, gonococcal meningitis, rat bite, fever. So sometimes they will ask you about this beta-lactam antibiotics. Beta-lactamase inhibitors or like suicide inhibitors. So they are effective against chromosomal beta-lactamases produced by Pseudomonas enterobacter. Amoxicillin with clavulanic acid, ampicillin sulbactam, piperacillin tazobactam, ceftazidime avibactam combination. So here it was only combined because of the specificity of carbamazepine is the drug of choice mainly for extended spectrum beta-lactamase group. It can be used penicillin produced in Neisseria gonorrhoeae and penicillin allergic patients. And this is what I prefer to write a drug which class belongs, oral or IV route of administration, what is the dosage, available formulation, mechanism of action, uses, side effect, toxic dose, toxic symptoms, excretion and drug interaction, and its use in pregnancy and lactation. How will you monitor the efficacy? For example, warfarin, you should monitor with PTNR values like that. Now sometimes they will ask you about antiplatelet drugs, which is nothing but your COX inhibitor. COX inhibitor is aspirin. They act as antiplatelet as they promote platelet, as they inhibit platelet aggregation. Phosphodiesterase inhibitor dipyridamole, ADP P2Y12 antagonist, which is a reversible blocker, cangrelor, ticagrelor, a reversible blocker, ticlopidin and prasugrel. GP2B3 antagonist, abscimab, eftifibatin and tirofiban. Platelet aggregation receptor antagonist, oropaxar, atopaxar. So this is my favorite topic, anticoagulant. Oral anticoagulant are vitamin K inhibitors, direct thrombin inhibitor, factor 10A inhibitor. So just remember this mnemonic. Factor 10A inhibitor, rivaroxaban, it is oral preparation. 10A inhibitor, apixaban, 10A inhibitor. Vitamin K inhibitor, warfarin, dicomaral, azenocomarin, phenydione. Direct thrombin inhibitors, zimalgatron, dabigatron, etixylate. Parental preparations are divided into direct thrombin, indirect thrombin inhibitors. Direct thrombin inhibitors are hyalurin, lepuridine, bevaluridine, ergotrobin and melagatron. The one thing similar to this is dabigatron, which is your direct thrombin inhibitor. Your direct thrombin inhibitor, ergotrobin, melagatron, dabigatron etixylate. Dabigatron etixylate is oral preparation, parenteral preparation. Indirect thrombin inhibitor or unfractionated heparin, low molecular weight heparin. Low molecular heparin example, enoxaparin, dalteparin, tinzaparin, fondaparinux and idraparinux. Idraparinux contraindication, renal failure. Tinzaparin only inhibits 10A factor. Heparin inhibits factor 2A and factor 10A. Warfarin, I want you to remember some basic things with respect to warfarin. Is metabolized by CYP2C19 enzyme, which is a drug interaction with proton pump inhibitor. Warfarin inhibits vitamin K dependent clotting factor 2, 7, 9, 10. So in that case, factor 2 half-life 6 hours. Factor 2 half-life 72 hours and factor 7 is 6 hours. Protein C, protein S, T of 8 hours. So they are also vitamin K dependent. These are anticoagulants. So this is procoagulant, these are anticoagulant, and these are also vitamin K dependent. In such case, warfarin inhibits protein C in S, which will cause avascular dermal necrosis. In teratogenic effect, it will cause fetal contrary syndrome. Heparin toxicity treated by protamine sulfate. Warfarin vitamin K injection, FFP can be given. The another one point warfarin is absorbed well from GAT is highly plasma protein bound 99%. Its kinetic change from first order to zero order within therapeutic concentrations. So heparin is safe in pregnancy, which will inhibit factor 10A and factor 2A. It will cause heparin-induced thrombocytopenia. Low molecular weight heparin has better bioavailability, long T-off, low risk of heparin-induced thrombocytopenia, low risk of osteoporosis. And low molecular weight heparin does not need any monitoring. So what are all the features of heparin-induced thrombocytopenia? Platelet count less than 1 lakh or decreased by more than 50%. More common with unfractionated heparin when compared with low molecular heparin. Starts within 5 to 10 days after starting heparin. Venous thrombosis is more common when compared with arterial. So how will you manage heparin-induced thrombocytopenia? First, stop heparin, warfarin. Continue lepuridine, which is your direct thrombin inhibitor, a parenteral preparation. Safe in liver failure. Argatroban, safe in renal failure. Warfarin is preferred in patient mechanical prosthetic valve, advanced kidney disease, creatinine clearance less than 30 ml per minute, which is stage 3 to stage 4 CKD. Moderate or severe MS cannot afford new drugs. Rivarox 7, which is a reversible oral 10A blocker. Sometime they will ask you about somatostatin octreotide. So this is secreted area. It will be useful in secreted area, esophageal varices, malignancy, acromegaly, TSH secreting adenoma, and overdose of sulfonylureas. If they ask you about bromocriptine, it is useful in diabetes mellitus type 2, prolactinomas, Parkinsonism, acromegaly, and milk secretion inhibition. It will suppress lactation. Sometimes they will ask you about GnRH analogs. GnRH analogs, if given in pulsatile fashion, it will increase the sex hormones useful for infertility and delayed puberty. If it is in a non-pulsatile fashion, it will decreases the estrogen, progesterone, and testosterone sex hormones useful for prostate CA, endometriosis, fibroids, and precocious puberty. GnRH antagonist will decreases the hormones useful for prostatic carcinoma and endometriosis. So, what are the GnRH analogs? Are besoline, goserelin, leuprolide, nafrelin. Cetrorelix, ganirelix, abarelix are GnRH antagonist. Sometimes they will ask you about for the treatment of osteoporosis, inhibits resorption, stimulates formation, both actions. So inhibits resorption, bisphosphonates, a monoclonal antibody, denosumab, sinorcalcet, calcitonin, estrogen, SCRM. Stimulates formation, teriparatine, calcium, calcitriol, and fluoride. Both actions, strontium, ranolate. I know it will be difficult to remember all these points. I want you to remember 5 points per each questions. Hear this video with headphones while eating, walking, whenever you are in free time, and if you are not ready to read the main subjects, just watch this video for 10 minutes and take a break. It will help you in your exams. So bisphosphonates are useful for treatment of postmenopausal osteoporosis, steroid-induced osteoporosis, PGETs, and hypercalcemia of malignancy. So if they ask you the question about steroids, I want you to remember 5 basic ones. Glucocorticoids, glaucoma, limb muscle atrophy, peptic ulcer, Cushing syndrome, osteoporosis, cataract, osteonecrosis, avascular necrosis, contraindication renal failure, contraindicated in TB, it will impair healing, contraindicated in CHF, it will cause edema, infection because of immunosuppression, diabetes mellitus, suppression of HPA axis. How does GnRH analogs and antagonist works? They will inhibit the release of gonadotropin releasing hormone from hypothalamus, thereby inhibiting the release of sex hormones from thereby inhibiting the release of FSH and LH from the pituitary. Ketoconazole and abiraterone acetate useful in inhibiting the release of testosterone. 5-alpha reductase enzyme inhibited by finasteride and dutasteride. Androgen receptors are flutamide, nilutamide, bicartamide, and cyproterone and spironolactone. So these are the drugs that will be useful in case of a prostate cancer or even endometrial cancers. Spironolactone is useful for hirsutism. So this is my favorite question. Dexamethasone suppression test. Dexamethasone given 1 mg per oral at 11 pm. Plasma cortisol measurement at 8 am the next day. If less than 3, then it is normal. If it is more than 5, then it is Cushing syndrome. Dexamethasone 8 mg per oral at 11 pm. Then you should measure plasma cortisol the next day at 8 am. If more than 50% reduction in cortisol level, then it is Cushing disease because of pituitary tumor. If less than 50% reduction in cortisol level, measure plasma ACTH levels. If it is low, then it is adrenal tumor. If it is high, it is ectopic ACTH production. So it is all based on the feedback inhibition property. So the steroids, we give externally dexamethasone. So if the plasma cortisol, there is more than 50% reduction, then it is Cushing disease. If it is not, then we have to look for other causes of excess cortisol. If it is plasma ACTH is low, then it is primary adrenal. If it is high, then it is ectopic ACTH production. Now just remember this colony stimulating factors. Granulocyte colony stimulating factors are filgrastim, sargramostim, which is both granulocyte and monocyte stimulator. Romiplastim is platelet stimulator. L-thrombopac is a thrombopoietin agonist. Peginacerin is erythropoiesis stimulating agent.